In this recording, I'll be discussing maternal age-related concerns. Women at each end of the childbearing age spectrum have their own challenges and risks, both teen moms and older moms. So I will be talking about both these populations. So teenage pregnancy. Teenage pregnancy does pose serious, significant risks both to the teen moms and also to their children. They are more likely to drop out of school and rely on public assistance, and they are more likely to live in poverty. According to the Center for Disease Control, about 33% of U.S. teens become pregnant before age 20, or 10% of all pregnancies occur to teenage girls. It's considered a major health problem in the U.S., where U.S. teen birth rates exceed those of most developed countries, including Canada. Our rate of teen pregnancy is 3 times the rate of Canada. About half of all teen pregnancies occur within 6 months of the girl first having intercourse, and about 20% of teen moms or teens who have become pregnant have another baby within 3 years. About 80% of teen pregnancies are unplanned, but not all of them, and we'll talk about that in a little bit. The good news is teen births are decreasing overall, and this is mainly attributed to increased contraceptive use. So obviously birth control education is very important, but we're discussing concerns once the pregnancy has occurred. And the teen birth decrease is seen as attributed to like I said, increased use of contraceptives, not a decrease in sexual activity. Teen pregnancy occurs across all socioeconomic groups, but there is a higher rate in the South and Southwest and in lower socioeconomic groups. And the rate is higher in teens of color. So there are many factors that complicate teen pregnancies. It's a unique group of women that have special needs related to physical and psychological development, as well as social issues. Physically, their bodies are still changing and maturing and developing. Developmentally, they're trying to develop a personal identity, a sexual identity, figuring out who they are in the world, and becoming pregnant can only confuse the matter. They're looking for freedom and independence, but yet as a teen they do continue to be dependent on parents and family. Adolescent pregnancy can be very emotionally charged with ethical dilemmas and decisions that need to be made. Physically, preeclampsia, which you have already learned about, the risk goes up significantly in women who are less than 20 years old. Physically, their development is not yet completed either, and so there's a greater incidence of cephalopelvic disproportion. Teens' nutrition tends to be poorer. They usually get less than 2/3 the recommended daily amount of calcium, vitamins, vitamins A and C in particular, and iron, leading to an increased rate of anemia in teens. And they often don't start their pregnancy with adequate weight to begin with. Psychologically, they're at greater risk also. Because the pregnancies are typically not planned, it may take them by surprise. They may not even realize they're pregnant for a while. They may deny the pregnancy to themselves. They may try to conceal it. They may be many weeks or months into the pregnancy before they even admit to it, and that leads to delayed prenatal care. And we know that early and consistent prenatal care is very important for a good pregnancy outcome. They are the least likely of all maternal age groups to get early prenatal care. Also, because of their lack of sexual experience, they tend to not use barrier methods of contraception and have a higher risk of STDs or sexually transmitted infections. They say that the 13 to 24-year-olds account for 26% of all new HIV infections. Also, because they are risk takers, there tends to be a higher incidence of drug, alcohol, and tobacco use, all of which are detrimental to pregnancy. And there is a greater risk of domestic violence in pregnant teens than other teens or other pregnant women, for that matter. And we will talk more about domestic violence in another video, another recording. This is just a graphic of smoking in pregnancy. The CDC says that in the U.S., 11.4% of all pregnant women smoke, 11.4%. And among the 15 to 17-year-old age group, that goes up to 13.4%. And in the 18 to 19-year-old age group, it goes up to 18.2%. So you can see that it increases significantly. Also, during adolescence, there are several important and difficult psychosocial developmental tasks that are occurring. And pregnancy can interfere with this process or can make it very overwhelming. There are different developmental theorists, but the one I'll be referring to, who is often cited, is Erik Erikson. And he talks about 3 developmental tasks that adolescents work at achieving during this time frame of their lives. The first one is achieving comfort with their body image. If you have had a teen yourself, or if you remember being a teen, they're very conscious of how they look, and how do they look compared to other adolescents. Any little detail or feature that they have physically, they're acutely aware of, and any changes are also very meaningful to them. So they are just becoming comfortable with the normal bodily changes of puberty and of growing during this time frame. And if you add a pregnancy to it, now not only are they gaining weight and is their stomach getting bigger, but their breasts may be getting bigger, they may be leaking urine, they may be constipated, developing hemorrhoids, varicose veins, dripping milk from their breasts, a lot of changes to their body, stretch marks perhaps, may start losing hair, many different things that can happen during pregnancy that obviously will interfere with their ability to feel comfortable in their own skin. Second important developmental task is achieving independence from their parents. And all teens go through that. It's normal to start pulling away from parents and becoming more independent and figuring out how to do that. If you add a pregnancy to it now, even though you might think that that forces them to become more independent, in fact, it forces them into more of a dependency position on parents, and can make achieving this developmental task even harder. And the third one is developing an adult identity. trying to figure out who they are, who they want to become, where they fit in the world. And as they're trying to learn these things about themselves, now you add motherhood or parenthood to it, and that makes this process of achieving this task even more difficult. In addition, as I said earlier, about 4 out of 5 pregnancies are unplanned. They have a sense of invincibility. It can't happen to me. I'm only doing it once. It can't happen. Or it may be because of ignorance of contraception or the inability to acquire contraception. Sometimes the pregnancies are planned, however. In an attempt to feel loved or important, they say, I wanted someone who would love me unconditionally, or someone that I could love completely. They may think it's fun to take care of a baby. It might be an attempt to feel special, or to maintain or cement a relationship with a boyfriend, or to gain status amongst peers. So there are some reasons that that the pregnancies might be planned, but most of the time they're not. And so when they find out they're pregnant, they can have feelings of guilt or shame, embarrassment. Also, about 50% of pregnant teens suffer from depression, and the depression is there prior to the pregnancy. So not only may the pregnancy be an attempt to feel better, but it also can actually cause the depression to worsen because of the feelings of lack of control over their life. Statistically, 80 to 90% of teens have been sexually abused in their life. It doesn't mean that a sexual abuse situation resulted in the current pregnancy, but they have a history of sexual abuse. So again, the pregnancy may be an attempt to gain some control over their life. And 78% of teen moms report intimate partner violence during the postpartum period. And we also know that intimate partner violence or abuse goes up during pregnancy as well. And we will talk more about that. Okay, socially, a pregnant teen may risk the loss of their support group, parents and family, classmates, peers, social groups, church groups. They actually risk losing what support they have. Statistically, 70% of pregnant teens drop out of school. The income of teen moms is about half that of women who give birth in their 20s, and 75% of pregnant teens receive public assistance within 5 years, so the incidence is much higher. They're usually not independent financially. They may not have a strong support system to begin with, and so when we look at what support there is for them, it may already be complicated by the support system not being strong to begin with. Medical complications. There are some medical complications that they're at higher risk for under the age of 20. Most of them they're not at risk for per se, unless they're younger than 16 years old, but they are at greater risk just because of other aspects, like the risk-taking, the poor nutrition, lack of life experience, that kind of thing. One physical complication that they are at greater risk for is preeclampsia. And you've learned about that already. The risk for preeclampsia goes up in any woman under the age of 20, and preeclampsia is one of the top reasons for maternal mortality currently, and so it is a serious concern. Teen moms are also at greater risk for preterm birth and for low birth weight infants. Both are significant problems for the babies. Higher risk of anemia and the problems that go along with that. And also a higher incidence of dystocia or difficult labor because of cephalopelvic disproportion, or the pelvis being smaller than the baby, trying to be born vaginally. Teen pregnancy affects not just the mom, but the baby as well. The postnatal infant death rate for babies of teens is 3 times higher than babies of moms in their 20s. And studies show 3 reasons that they believe this is. The first is there's an increased incidence of abuse and neglect amongst teen parents. That sounds harsh, but when you think about it, these are people that don't have as much life experience with coping and problem solving and knowing how to handle stressful situations. The second thing that is seen as correlated with the infant death rate among teens is the absence of the father of the child. And that is probably because there is less support for the mom as well. And the third reason is that there is an increased incidence of SIDS, or sudden infant death syndrome, which you will learn a lot more about in pediatrics. So, nursing implications. Well, pregnant teens face ethical dilemmas and decisions, whether to continue the pregnancy or terminate the pregnancy, whether to keep the baby or place the baby out for adoption, or possibly place the baby in foster care. They may choose to place themselves in foster care. And we need to help them identify their feelings, verbalize them, and assist them to find the support they need to make the decisions that need to be made. You may be the only non-judgmental adult they have to talk to. And as a nurse, it's important that we recognize what our moral beliefs are and to realize that that could influence our care. It doesn't have to, but if we believe that it could interfere with our ability to give non-judgmental care, then we need to step aside so that the teen can get that care. So you need to think about, how do you feel about teenage pregnancy? How do you feel about a young teenager taking a baby home and planning to raise them? What about if that young teenager is only 13 years old? How do you feel about that? So we need to be that patient advocate and that support person for them. We need to assess what their support system is, not just family, but peers as well. We know that even though it would be nice to think that as parents, if you're a parent of a teen, it would be nice to think that they look to us first for support, but we know that when it comes to teens, that peers are the most influential. So what kind of peer support do they have? We also need to identify appropriate referrals and community resources, or find somebody that does know these referrals and resources for them. It may be WIC, Women, Infant, and Child Program, Medicaid, SNAP or food stamps, might be a high school program that allows them to continue their classes during pregnancy, or provide support to continue with school after the baby's born as well. And we need to continue to provide prenatal supervision and teaching, to make sure that they do keep coming back for prenatal care. And we want to keep a special close eye out to watch for signs or symptoms of preeclampsia and preterm labor, since we know that they are at greater risk for this. So help them think about their feelings, make decisions, be an advocate for them. Involve the baby's father. And sometimes that's difficult because teen dad is still a teen boy and is going through some of the same developmental challenges that the mom is. But we know that having the father of the child involved, even if he's young, provides increased support for the mom, and we have better outcomes. You need to know the laws related to emancipation and consent for treatment of minors, and this varies by state. In Colorado, in the absence of an emergency, only the parents or legal guardian of a patient under the age of 18 can give a valid consent on behalf of the minor for health care and healthcare treatment, with some exceptions. If a minor is at least 15 and is emancipated, and I'm not going to go into what emancipation is, it's a legal definition. And then there are other exceptions related to treatment of things such as addiction to drugs, alcoholism, venereal disease, AIDS and HIV testing. They can make decisions, a minor can make their own legal decisions related to birth control or family planning. They can get treatment for sexual assault and mental health services. And one exception is that a minor may make healthcare delivery or healthcare decisions for themselves related to prenatal care, delivery, and post-delivery medical care for herself related to the intended live birth of a child. So, a minor, pregnant, or postpartum patient can consent to her own treatment related to herself and related to her newborn, and the patient's parents have no right to override any of her decisions, nor do they have any rights to the patient's protected health information without consent of the patient. And the minor patient makes all the decisions for treatment of her newborn as well. And so it's interesting, if mom is a minor, she makes all of her own healthcare decisions during the pregnancy and delivery and for the first 6 weeks after delivery. After that, the decision-making reverts to her parents or legal guardian, although she does retain legal decision-making ability for her offspring. But while we're taking care of them during the pregnancy, they're in charge of decisions. Older expectant parents also have age-related concerns. The number of first-time pregnancies over the age of 45 is going up. A study done 4 years ago showed that first-time births over the age of 45 have more than tripled over the past decade. Some of the concerns that older women have when they become pregnant, one is, will they have enough energy for raising a child in 10 to 15 years? It's a major lifestyle change. They have lived maybe 40 or more years with a certain lifestyle, and now bringing childbearing and child rearing into it is a big change. They're also forced to face their own mortality by looking ahead. How old will I be when my child starts school? How old will I be when they graduate from high school? Will I live to see them become married or have children of their own? All of those things these women look ahead and think. Some of the reason that these older first-time pregnancies are going up is that women are continuing their education or seeking a professional career. Sometimes they don't think about starting a family until later. So what are some of the issues for older parents? Well, first of all, there's not as much social, community, and family support as there are for younger women. If you think about it, if there's a woman who's 40 years old and tells her friend, and has never been a mother before, and tells her friends, "I'm pregnant," what type of reaction will she probably get? Do they say, "That's wonderful, that's great," or do they say, "Oh my gosh, what are you thinking? Better you than me. Are you crazy?" That's, even if kidding, that's the kind of response they often get. They worry about fitting in. With prenatal classes, are they as old as most of the pregnant women's mothers? Will they fit in at school with the parenting groups at school in PTO or PTA? And other social groups. Sometimes they wonder, will they be older than all the other moms present? Interestingly, the older expectant moms are the second largest group of unplanned pregnancies, next to the teens. While you would think older and wiser, it's not so much that they don't understand about birth control and that they don't have access to birth control. It's that they aren't expecting to be pregnant. They think they're perimenopausal and safe. Their periods are irregular, and they don't think that they're at risk of getting pregnant. Another thing about later pregnancy is often these women have a history of infertility. It's not that they necessarily put off childbearing, but that they haven't been able to get pregnant until this point. Or it may have taken a lot of work to become pregnant if they were having problems with infertility. And we know that infertility treatments can increase the risks for a healthy outcome for the baby and increase the risk of congenital problems also. Statistically, a 30-year-old or younger has a 5 to 10% chance of infertility. By 40 years old, that goes up to 40%. And by 45 years old, women rarely can conceive without some kind of assistive technology. However, the good news is women who do conceive after age 40 have greater longevity. It's a sign that it may be a sign that they're aging slower, and so they do well. Here's a graphic that shows the change in infertility problems between a 30-year-old and a 40-year-old. Goes up a great deal. Okay, some of the physical risk factors. All pregnancies over 35 years old are considered high risk, and the risk goes up every year. Especially at age 40, we see statistically an increase in problems. One study that looked at women who gave birth between ages 45 and 65, 30% of them had a chronic disease such as hypertension or diabetes. So a greater incidence of pre-existing or chronic health problems. Women over the age of 38 have twice the likelihood as younger women to develop high blood pressure or diabetes during pregnancy. One study showed that of women over 40 years old, 40% of them develop diabetes during pregnancy, and 20% of them develop preeclampsia. So the risk does go up quite a bit. There's also a higher risk of first trimester spontaneous abortions, probably due to chromosomal abnormalities. And if you have a woman that's been dealing with infertility already and trying to get pregnant for a long time, the grief can be even deeper for these women. Older women are also more prone to difficult labors, longer labors, and C-sections, the requirement for C-sections. And there's a higher incidence of fetal demise, which is death of the fetus from 20 weeks on till birth. Higher incidence of preterm delivery and of small for gestational age babies. And they think that this may have to do with poorer circulation the older women get, decreased circulation. There is a higher incidence of maternal mortality in older moms, older pregnant women. And there is an increased risk for some congenital disorders. Probably the highest risk is with trisomy 21 or Down syndrome, where there are three 21 chromosomes. Here again is just a table. At age 25, the incidence of having a Down syndrome baby are 1 in 1,250. By age 30, it goes up to 1 in 1,000. By age 40, it's 1 in 100. And by age 45, it's 1 in 30. So the risk goes way up. And this picture at the top of the screen, you can see chromosome 21. There's 3 of them here in this karyotype. So nursing implications. First of all, preconception planning is especially important. Of course, we say that's important for any pregnant women, but older pregnant women are especially in need of this for various reasons. Okay, first of all, let's see. First of all, we want to make sure that they're in the best of health, that their weight is in a healthy category, that if they do have pre-existing conditions like diabetes or hypertension, that they are in the best control possible before becoming pregnant, and that we educate them about possible changes in lifestyle that they'll need to make. So early and regular prenatal care is important as in any pregnancy, and you would think, well, why mention it with older women? And the reason is that often they think that that's not important for them. They educate themselves through reading books, going on the internet, and they're busy people and don't necessarily think that they have to go in for regular prenatal care. So we need to educate them about that. Also, older women, if they have bad habits like smoking, drinking, I don't know if that's a bad habit or not, drinking coffee or caffeinated beverages, we need to talk to them about not doing that during pregnancy. And that may be tougher for them to give up if they've been smoking or drinking coffee or used to having their cocktails for 20 or 30 years. We also want to encourage them to attend prenatal classes, which a lot of times they don't want to. They feel out of place. Again, they feel like they don't need it, but because there is a greater incidence of difficult labors and an increased need for C-sections, it's especially important that they get this education. And some communities have classes specifically for older parents to give each other support. And we need to make sure that she and her family are prepared for the possibility of a C-section, that they know that this is a possibility. We may, or the care provider may choose to offer a diagnostic amniocentesis, an alpha-fetoprotein test, or chorionic villi sampling to look for chromosomal abnormalities. And if abnormalities are found, we want to assist the mom and her partner in becoming as educated as possible about whatever the abnormality is, to be able to make an informed decision about whether to continue the pregnancy or not. And whether they choose to continue the pregnancy or not, this was an outcome they hadn't planned on and didn't want, and we need to support them in their grief and in any decisions that they make. Sometimes parents will say, well, I'm not going to have a chorionic villi, or I don't want to do an amniocentesis because it won't change my mind about continuing the pregnancy, so why should I? And, that's okay. However, knowing what's going on with the fetus helps plan for the pregnancy as well. So there is a case for having the diagnostic testing done, even if terminating the pregnancy is not a consideration for that family. Fortunately, both with teen moms and with older moms, the pregnancies can be healthy with healthy outcomes, and our job is to support them and educate them and help support that that's the outcome that we have with the pregnancy.